Buenas tardes, primero en español. Buenas tardes a todos. Vamos a comenzar la mesa después de la comida. First of all, on behalf of the organizers of this symposium, I would like to thank to the sponsors for their contribution and collaboration in this symposium. Just now, I will present and introduce the first speaker, Dr. Carlo Gabriele Tocchetti. He is the director of the Cardio-Oncology program at Naples University, Italy. Please, Carlo. Carlos.
Okay, it's great to be here. I can't thank, Teresa, anymore. I mean, it's a great city, and we really like to stay here. And thank you so much, Teresa, and to whatever organization you put together. This is amazing. Thanks so much. So we had some great presentation this morning, and I will sure repeat something that has been already said. Nevertheless, we'll try to be original and present also our own data on the topic. It's true. I mean, there are some common pathophysiological features in cancer and cardiovascular disease, especially in heart failure. That's basically what we do, heart failure and cardio-oncology. And cardio-oncology, in the way that cancer and heart failure have dangerous liaisons. So that's why I slightly modified the title of the talk. This is a slide in Italian, but it's pretty understandable in Spanish as well. I think the word doxorubicin is pretty, international somehow. And basically here and even myocardiopathia, cardiomyopathy, right? So this is a slide from a 2003 paper, but basically here we show that the cardiomyopathy due to doxorubicin therapies has bad mortality, compared to the other cardiomyopathies. So this is already something. Heart failure is bad, cardiomyopathies are bad, dilated cardiomyopathy is bad, but the one due to doxorubicin is pretty, one of the worst. So the attention and focusing for heart failure people, towards cardio-oncology is very, very important. And it's true that in the industrialized world, cardiovascular disease and cancer are the leading causes of death in the aging population. And this is something that, came out, only yesterday, at the dinner, we were talking of this. And, aging, cancer, and cardiovascular disease are all connected together. And cardiovascular disease and cancer account for basically 50% of all deaths. And this is a study which actually shows that heart failure, which sometimes people who are not, cardiologists, don't really consider that much. Basically, heart failure has a better prognosis only of lung cancer. And so the other cancers, which already in 2017, but now with the immunotherapy, immunological therapies, really are changing the fate of the other cancers as well. I think heart failure, though, still has lots of burdens for hospitalization costs and mortality. And it's a chronic disease which is worse than basically any other cancer survivors. Because people who survive cancer have chronic disease as well. And so the aim of our talk and the themes that we are discussing today, were already put out in papers, with most of the people that are sitting here in the audience. This one from 2018, and this one is from 2020. And I will try to, explain these papers and add our own personal experience and personal research. So cardiovascular disease is actually the most frequent non-cancer cause of death. And you see how frequent it is in prostate cancer. Of course, maybe not so much in lung cancer because people die of lung cancer. But in the other cancers, people survive and they get cardiovascular disease. And the Danish database clearly showed that there is more cancer in heart failure people. Heart failure people can develop cancer. And of course, worse prognosis is present when they both co-occur. And this situation is not so uncommon because, again, people are surviving from an MI, they do develop heart failure, they live, they do develop cancer. And so this is a real challenge for clinicians every day. This is another study which clearly shows that maybe not in the 70s, but in the 2000s, heart failure patients are at increased risk of cancer, and indeed it has increased over time because people are actually living more, living longer. And cancer, of course, increases mortality in heart failure, and so it is important to survey for non-cardiac morbidity or cancer in the management of heart failure patients. But this is true not only in the long time, but even in the short time. This is just 5 years after incident MI, and there is increased incidence of cancer among heart failure after 30 days myocardial infarction. Patients who basically develop heart failure after myocardial infarction have more chances to develop cancer. Why is that? I mean, Dimitrios, Peter, Alex already said this morning. Heart failure and cancer share basically same risk factors: aging first, smoking, obesity, diabetes, dyslipidemia, alcohol intake, and also this is the real concept. Cardiac disease may promote cancer, and cancer may promote cardiac disease. This is a very nice editorial from Wouter Myers and Rudolf de Boer. They are, I think, now both in Rotterdam, but they were in Groningen when they wrote this, in which basically there are shared risk factors between heart failure and cancer. There are some drugs interactions, the microenvironment of cancer, with angiogenesis, inflammation, and the matrix. There are cells that are important in both situations, like fibroblasts, endothelial cells, inflammatory cells, extracellular matrix. And even the clinical presentation may be completely, connected in heart failure and cancer. Sometimes one may mimic the other one, and I will show you. This was a very nice study, again, from Wouters and Rudolf, in which basically they showed that inducing heart failure in the mouse experimentally after myocardial infarction this heart can secrete some circulating factors which can increase tumor growth. And here in the editorial by Rick Kitts, he summarizes the paper, and basically what they did, they had myocardial infarction by coronary ligation, they explanted the heart in these mice, and they implanted into a model of colon cancer, but not in a way that it can hemodynamically condition the circulation, but just behind the ear. So to have a stable situation. But what they found is that serpin, fibronectin, ceruloplasmin, were some factors which they studied, and they saw that on HT29 cells in the dish, they induced proliferation. But this thing was also validated in a cohort of heart failure population. You see in the congestive heart failure population, these factors are elevated. And so the paradigm that actually stems from this study is that there are risk factors, but there are circulating factors that can, induce heart failure, and these other factors can induce cancer. This is an extremely interesting study. Also, heart failure and cancer can show similar symptoms like fatigue, dyspnea, weight loss, muscle wasting, edema. And interestingly, symptoms due to a tumor may also overlap with those of heart failure, and actually may be mistakenly attributed to heart disease. I mean, we are cardiologists, so the first thing that we think is when we see like a fatigue patient, we think he has heart failure. And these are absolutely cases that we see in our clinical practice. We lost an heart failure patient because of cancer. This situation may delay cancer diagnosis, and it's true. We thought, okay, this guy has worsening heart failure when we had liver cancer. As symptoms might be thought to be due to advancing disease rather than to new cancer. This study is from Stefan von Healing group in Germany. And they actually show that the cardiovascular function and even predictors of exercise capacity are basically impaired in colorectal cancer. So patients who have healthy heart do the CPET, and basically these parameters are impaired in colorectal cancer regardless of the chemotherapy. So it's cancer itself may affect cardiac function. And Noemi Pavo in Austria showed actually that even NT-proBNP is elevated in patients with cancer. So definitely there must be some interaction by the cancer microenvironment, inflammation, growth in the heart. And for the echo people, this is a study from Eugenio Picano, who is pretty well known by the echo people. Even the positivity to stress echo can predict cancer death. It is also possible that heart failure therapies can actually render clinically overt tumors that would be otherwise asymptomatic. For instance, if you have a silent prostate carcinoma, you can just reveal it by difficulty in voiding in response to diuretics. For instance, you have a patient in your wards, in your heart failure wards, and you discover that he has prostate cancer. Or, this is absolutely common to us, intestinal neoplasms that start to bleed due to chronic antithrombotic treatments. How many times you have a PCI, patient starts antiplatelet treatments, and then you discover gastric cancer or some ulcer that is actually cancer. And this is other interesting data is that there has been found a positive correlation between treatment with medication that may be used for heart failure, like angiotensin receptor blocker or even ACE inhibitors. And these are data from the SOLVE and the CHARM studies and risk of cancer. But the point is that it's not these drugs that induce cancer. The point is that it's completely the opposite. These drugs save lives. Patients survive from heart failure. They have more time to develop cancer. So it's obvious that the association with these drugs, these are associated with longer prognosis and more chance to develop cancer. And in fact, this is exactly a study which shows the opposite. Here, actually, the study shows that patients on angiotensin system inhibitors may actually benefit from having angiotensin system inhibitor as a therapy and as a therapeutic potential strategies in metastatic renal cancer. And even in this study, neoadjuvant therapy with FOLFIRINOX in combination with losartan, followed by chemo for locally advanced pancreatic cancer, losartan could actually improve the prognosis in these patients. So there are so many interactions going on, so many things that we still don't know. These are other things that maybe for us may seem easy and obvious, but cancer patients on lower heart rate or lower resting heart rate live longer. It was a study by Markus Anker in Germany. And so people, with heart rate lower than 75 BPMs with cancer, have a better mortality, both 1 year, 2 year, and 3 year mortality. But the interesting thing, so we treat, heart failure patients with beta blockers, but the interesting thing is that there is also beta-adrenergic modulation of cancer cell proliferation. So there are preclinical observations suggesting that inhibiting the beta-2 adrenergic signaling pathway can actually reduce breast cancer progression and mortality. So actually, some of the drugs that we commonly use for heart failure, patients with cancer can benefit from them. This data, this is a 2011 data, and I was speaking to Tashimi earlier on, and actually in those days, we, as heart failure people, became interested into cardio-oncology because we went back to some previous studies. This is a PNAS paper from Alejandra Negro. She was in San Diego, and she actually observed that there was an interaction between the beta-2 adrenal receptor and ERB2. In the heart and in brain, they were co-immunoprecipitating, and so they were physically close, and we thought that there was something going on and some interaction. So while this Nature Medicine paper from San Diego as well was there since 2002, and basically the authors knocked out ERB2 in the heart, and the mice developed dilated cardiomyopathy with increased apoptosis, vacuolization, and myofibrillary disarray, we built the opposite mouse. We overexpressed ERB2 in the heart, and we saw these things. The assumption was that, indeed, ERB2, the absence of ERB2 was actually negating the heart, an important compensatory mechanism, because the guys in Groningen had previously shown that the levels of circulating ERB2 is actually higher in heart failure patients as a compensation mechanism. And there's Dirk van Veldhuizen's papers back when Peter was fellow, I think, there. And so when actually the contractile function gets lost, it's because ERB2 is somehow exhausted. So we did the mouse, and we actually saw the largest hypertrophy I'd ever seen in those days. Some concentric cardiac hypertrophy in ERB2 overexpressing mice, something that we never saw this way. It was difficult to cannulate the aorta. It was massive hypertrophy. We went to check with Western blots, and we saw that there was upregulation and activation of ERB2 family and downstream pro-hypertrophic proteins. that was clear. And of course, there was pro-survival proteins, upregulation of these proteins in ERB2 overexpressor hearts. And what we saw, to get back to the interactions between ERB2 and beta-adrenergic response, we saw that indeed the amount of response to Zintrol, which is a beta-2 agonist, was increased. And again, so it rang a bell, beta-2 and the ERB2 receptors have some connections then. And when we transfected ERB2 in Higg cells, we saw upregulation of beta-adrenergic receptor, beta-2 adrenergic receptor, and vice versa. So again, this interaction was really there. And when we gave isoproterenol to the wild-type mice, both ERB2 and the beta-2 adrenal receptors and phospho-ERK were increased. So again, Groningen. The Corte showed that trastuzumab marked with indium could actually identify patients susceptible for trastuzumab-related cardiotoxicity in patients who had done anthracyclines. Why is that? Because the heart has suffered an insult. ERB2 was upregulated. Trastuzumab was actually marking these upregulated cells. And so the hypothesis that we generated was that myocardial insults increases catecholamines, catecholamines act on the beta-adrenergic receptor, and this acting increases ERB2 in a protected signaling. But when with these patients do trastuzumab or whatever anti-ERB2 therapy, of course, this ERB2 on the heart will be unfortunately targeted as well, and this will go to cardiac dysfunction. So the protection of the heart with beta blockers can actually stop this circle, and ERB2 will be just on cancer cells and not on the cardiac cells. And the good thing was that years later, the study from Gullin in JAC 2019 actually showed that indeed carvedilol was the drug for trastuzumab after anthracycline exposure in the breast cancer patients. So as heart failure people and cardio-oncology people, we have this kind of problems. We have that heart failure people who develop cancer sometimes have cancer-related mortality, they have heart failure-related mortality, but basically it's difficult to follow them, when to implant ICD, when to implant the VAD, they are excluded from transplantation, even giving cardiotoxic drugs to them, it's difficult, and that's how the guidelines really help in this situation as well. And we all face this situation, stick with the heart failure guideline management, stick now with the cancer management, but then interact, and this meeting is the example, we really need to interact with the oncologists. Oncologists need to interact with that to warranty the best treatment that we can assure. Because indeed, what do you do when you have heart failure patient and this heart failure patient has cancer? You need to give him these drugs. You can't, just condemn him to death without giving him these drugs. And that's why the so-called permissive cardio-oncology is important. And the SAFEHEART study is important because they're actually treating with trastuzumab, patients who have developed a, let's say, mild decline in heart function. Because these guys, if we do surveillance, we see them more often than other people who really don't need to be seen that often. Okay, so not to saturate our labs. Then these are the people who actually need to be followed up with a stricter follow-up. And this was already there in the heart failure guidelines from last year, so from 2021. So this part, and Alex was on this part as well. Cancer patients has increased risk for cardiovascularity. We've been talking about this morning. Raul spoke about this morning. Really have a class 1, recommendation to do the cardiovascular risk assessment. It's there now. It's even in our guidelines in cardio-oncology guidelines, which were developed, right after these ones, and rely on these ones. I'm not showing the cardio-oncology guidelines because you already have the queen of cardio-oncology and the king this morning speaking of that. But it's absolutely there. And this one was already in the heart failure guidelines. So how do you manage the patients receiving potential cardiotoxic treatments if they already have heart failure? You stratify the risk, you divide the risk. If they are medium and high-risk patients, like patients who already have heart failure or cardiomyopathy, reassess these patients more often than the other ones. It's us who have to follow the patients. I'm skipping on this because it was already shown, but this slide, I really like it. And you see that indeed heart failure and cardiomyopathy, have a very high risk of cardiotoxicity, with anthracyclines, with HER2 target therapies, with all the therapies, of course, people who do worse or need a lot of surveillance are heart failure people and cardiomyopathy people. I'll skip on this as well. Raul showed this. And these are some of the experiences that we've done. This is a multi-center study that we did together with the Genova people who are really close friends of us. Paolo, Pietro, and Italo are very close friends. So we teamed together, and we did so according to the HFA-ICOS tables that were shown earlier this morning. Indeed, that the patients who are at higher risk are the ones who develop more cardiovascular events. So these are the ones that we need to follow. And after that, we checked at our own data, and we had divided the patients in 3 categories. Patients who came to us before doing the cardiotoxic treatments, patients who came to us during the cardiotoxic treatment, patients who came to us after cardiology treatment, the oncology treatment. So let's say the patients who came to us after the oncology treatment were already, cancer survivals, patients who basically did already well. So they did not show a real difference of prognosis and the cumulative survival compared to the patients who start cancer therapies after that we've seen them. The real difference was with patients who were referred to us during oncology treatments because they developed some cardiotoxicity or because the oncologist was afraid because they were high-risk profile. But maybe if we had seen them in the green line before the administration of cancer treatment, then this patient would have been in the green line because there was no difference in the profile of risk, in these populations. The green and the red were the same. The point is that one was seen earlier on, the other one was seen during. And so the recommendation is always the same. Baseline cardiovascular risk assessment. Thank you so much.
Thank you, Carlo. The next speaker is Daniela Cardinale. She is the director of the Cardio-Oncology program at the European Cancer Institute in Milan. Thank you, Daniela. You can start.
Thank you, Mr. Chairman, dear colleagues. Good afternoon, everybody. Teresa, thanks for this greatly appreciated invitation. It's great to be here in Madrid again. So let me start by asking a first question. Why use cardiobiomarkers for cardiac surveillance of cancer patients during their pathway of care? Because at present it's absolutely anachronistic making a diagnosis of cardiotoxicity on the basis of heart failure symptoms occurrence. Anachronistic and, let me say, irresponsible. But we well also know that also a diagnosis based on the evidence of an asymptomatic left ventricular ejection fraction drop. It may be a late diagnosis too, because the cardiac damage may be in many cases progressive and irreversible. We demonstrated this in a large prospective study including 2,625 patients who received anthracyclines and was closely monitored with standard echo. And in 9% of them, 9% of them developed cardiotoxicity, and we promptly initiate a treatment with ACE inhibitors and beta blockers. Most patients, 81%, were asymptomatic, and cardiotoxicity was detected at the already planned echo checks. So we promptly started ACE inhibitor and beta blockers, possibly in combination, in 90% of patients in combination. And we obtained a recovery, I mean a final value of left ventricular ejection fraction better than 50% in 82% of them. So we could say a good result. However, when we analyze in detail the characteristic of the patient who recovered, we found that only 11% had a full recovery, I mean a final ejection fraction level value equal to baseline. Most patients, 71%, improved their cardiac function and normalized their cardiac function, but the final value of the ejection fraction remained below the baseline value. So we suggested that we have to make a diagnosis of cardiotoxicity earlier. Cardiotoxicity is possibly a continuous phenomenon starting with myocardial cell injury, followed by myocardial deformation alteration, followed by an asymptomatic decrease in left ventricular ejection fraction, which, if disregarded and not treated, progressively leads after months, after years, to overt heart failure. We can identify cardiotoxicity, at each of these steps, depending on the diagnostic tool we use. At present, we can identify cardiotoxicity very long before the occurrence of heart failure symptoms, long before an asymptomatic decrease in left ventricular ejection fraction by biomarkers. And we started many years ago evaluating biomarkers, in particular troponin, and in our research scientific pathway, we demonstrated that the release in troponin after high-dose chemotherapy is a predictor of future left ventricular dysfunction development. We confirm with result in a population of breast cancer patients treated with anthracyclines, high-dose anthracyclines therapy, and more recently in breast cancer patients treated with trastuzumab. Then we observed that different patterns of release, of troponin release, corresponded to different level of cardiac risk in patients treated with high-dose chemotherapy. And then enalapril, enalapril therapy given to high-risk patients, I mean patients showing troponin release after chemotherapy, is able to prevent the development of cardiac dysfunction. We demonstrated this first in a single-center randomized trial, and more recently in a multi-center randomized trial, including 21 Italian centers. On this basis, we developed an algorithm that we have used and we use in our daily clinical practice. A baseline cardiological evaluation and assessment of troponin immediately before and immediately after each cycle of chemotherapy, mainly anthracycline-containing therapy, chemotherapy. In case of troponin rise, we promptly initiate a treatment with enalapril that would continue for 1 year. closely monitoring the patient. In case of troponin negative value, we don't close monitoring the patient. And after 15 years of this kind of approach, we didn't observe significant decrease in ejection fraction, no heart failure cases, no cardiovascular deaths. At the beginning, data demonstrating troponin as predictor of anti-tumor drug-induced left ventricular dysfunction came only from publication from our groups. But later, several studies have been published in Europe, studying of animal models. Later, the interest in this topic grew up importantly, and there was a proliferation of publication on this topic worldwide. Particularly in the recent years, when high-sensitive methods of assay have become available. Finally, very recently, the role of biomarkers in cancer patients receiving cardiotoxic cancer therapy have been included and suggested also by international guidelines. This is the first position paper published 2 years ago that states that biomarkers may be useful in baseline risk stratification, in early diagnosis of cardiotoxicity, in the identification in patients who will benefit from cardioprotective treatment and who may deserve or require a closer and long-term follow-up, and also to identify patients who don't deserve a closely monitoring, avoiding an unnecessary cardiac imaging program, particularly in this pandemic period not finished yet. Second question, when use cardiobiomarkers for cardiac surveillance of cancer patients? This position paper I showed you and that you well know suggests the use of both BMP and troponins, BMP and NT-proBNP and troponins, in patients treated with anthracycline, HER2 target therapies, antivascular endothelial growth factor therapy, and immune checkpoint inhibitor. With the timing, the frequency, must be tailored to each biomarker, kind of cancer therapy, and the level of cardiovascular risk. And the level of cardiovascular risk is suggested by this second position paper already presented, in a position paper from Cardio-Oncology study group of the Heart Failure Association of the ESC in collaboration with our International Cardio-Oncology Society. And in this position paper, a specific score is attributed to a specific risk factor. And according to these pro forma, this as an example for anthracycline's chemotherapy, a patient scheduled for potentially cardiotoxic cancer therapy may be at low, medium, high, or very high risk for developing cardiotoxicity. And finally, this new concept of a continuous surveillance at baseline, during treatment, and after treatment, including biomarkers, and which monitoring is, intensity of monitoring depends on the level of cardiovascular risk, have been assessed, has been confirmed in the recent, as you know, ESC 2022 ESC guideline of Cardio-Oncology presented 2 weeks ago in Barcelona. Let me show you 2 clinical examples, 2 patient categories who may in which the use of biomarkers may be very useful. These two categories are high-risk patients for developing cardiotoxicity. The first are patients with a pre-existent cardiac disease. This patient, as this is a clinical example, with multiple cardiovascular risk factors, with post-ischemic hypokinetic cardiomyopathy, with a reduced left ventricular ejection fraction, that these patients have frequently rejected and excluded from effective cancer therapy because considered to be at a too high risk. For this patient, we created a specific algorithm based on a multi-marker approach. The patient is admitted to hospital to receive chemotherapy. We monitoring troponin and BNP, both the biomarkers at baseline, soon after chemotherapy and before discharge. We repeat this at each cycle of chemotherapy administration, and we monitor regularly cardiac function. In this case, this is a recent example. This patient received 4 cycles of carboplatin and gemcitabine as suggested by the oncology guidelines. And troponin, as you can see, remained in the normal range. BNP was already increased, not surprisingly, and increased further after the infusion of chemotherapy, but the value came down and come to the baseline value after discharge. And the cardiac function remained stable without worsening of the underlying cardiac disease. So the patient concluded his neoadjuvant therapy and underwent lung resection. We followed in this way more than 600 patients, and we didn't observed significant reduction in cardiac function without the occurrence of cardiac events. And we suggest that this approach is feasible, is safe, and allows for also this patient to receive an effective cancer therapy. Another class or category of patients in which the assessment of both biomarkers, BNP and troponin, may be useful is the management of trastuzumab cardiotoxicity. As you well know, an asymptomatic decline in ejection fraction or symptomatic decline in ejection fraction may occur in up to 25% of patients treated with trastuzumab. Differently from anthracyclines, cardiotoxicity typically manifests during treatment, not after the end of treatment. And this can result in incomplete breast cancer therapy and in increase in cancer recurrence. If trastuzumab could be administered in a safe manner to patients who develop a reduced left ventricular ejection fraction, remain poorly understood and no randomized trial exists. So in this study, we evaluated the impact of a cardiological approach, including the assessment, combined assessment of BNP and troponin in terms of adherence and continuation of oncological therapy with trastuzumab. We included 84 breast cancer patients treated with trastuzumab who developed a decline in ejection fraction. 57 patients were allocated to the cardio-oncology management approach that included strict control of cardiovascular risk factors, prompt initiation of ACE inhibitors and beta blockers, echo and electrocardiogram were performed every month after resuming. Troponin and BNP was assessed at each cycle after resuming, and also heart failure therapy was managed according to troponin and BNP values. Clinical data were timely shared with oncologists. On the other hand, 27 patients were allocated to standard care, in which the stop and resumption, time to initiation of heart failure therapy, electrocardiogram and echocardiograms schedule were at the discretion of a treated oncologist and cardiologist. The two populations didn't differ, was not different regarding cardiovascular risk factor, previous cancer history, previous cancer therapy, administration. All the patient approaches with the cardio-oncology care resumed trastuzumab and completed the trastuzumab treatment. On the other hand, in patients with standard care, no patient resumed trastuzumab, and the decision not to resume were oncologist choice in 55%, the most important frequent reason, patient choice in 26%, and in 19% for the evidence of a reduced left ventricular ejection fraction. So this suggests that first, a collaboration with cardiologists, between cardiologists and oncologists is pivotal in this patient, and that the patient herself has to be correctly informed about the advantages of this collaboration. Notably, in patients who resumed the complete trastuzumab, overall survival and oncological survival was significantly better. So we have a positive impact on both oncological and cardiological outcome. And that's all. Thank you.